the students can take the lead. We've got 25 minutes, and then we'll have time for questions afterward from our judges. So go for it when you're ready.
Okay, hello everyone. Welcome to our geriatric case competition presentation. Members included Patrick, Alyssa, Jan, Katie, and McKenzie. Our coach was Dr. Nick Schneeman. Let's get into the presentation.
Okay, so before jumping into the case, we thought it would be best to start with some case-specific topics. As of 2021, the Alzheimer's Association published that around 6 million Americans aged 65 years and older are living with Alzheimer's dementia, and by 2050, the number of Americans living with Alzheimer's is expected to double. It is estimated that in 2022, Alzheimer's and other dementias cost the U.S. economy $321 billion and is estimated to cost nearly $1 trillion by 2050. Caring for a person with dementia is complex and can vary with each type of dementia, the disease stage, and each individual's patient circumstances and preferences. Despite the improvement since the 1970s, there remains significant burden on patients, caregivers, providers, healthcare delivery systems, and the economy. Currently, there's no gold standard model of care for dementia. A recent systematic review completed by the Agency of Healthcare Research and Quality found a lack of current interventions with strong evidence of benefit to improve care of people with dementia. People who identify as LGBTQ+, also living with dementia, face their own set of challenges in today's healthcare environment. For example, this population are more likely to exhibit vulnerabilities that may exacerbate how Alzheimer's manifests and its impacts. They are found to have higher levels of social isolation and face stigmatization, making it even more difficult to find support. Older LGBTQ patients have experienced historical discrimination and years of codified discrimination that has shaped their experiences that continue to impact them into their later years of life. People like Bob, who are living with HIV, also face additional chronic stress related to the stigma of their HIV status. This may prevent some seeking social support and medical care. In addition, people living with HIV experience disproportionately high rates of trauma. There is also a lack of healthcare providers who know the particular healthcare needs, stigma, and experiences of those living with HIV/AIDS. Next slide. The one intervention from the previously mentioned systematic review that had strong evidence to improve care of those with dementia is a collaborative care model. This type of model utilizes an interprofessional transdisciplinary team to provide care for patients with dementia and their caregivers. These models have been associated with reduction in behavioral symptoms, improved functioning and quality of life, less frequent use of acute medical services, and decreased caregiver burden. Thus, our group believed that the best way to care for Bob and Jim in this case was to be a collaborative care dementia clinic we envisioned for the future. This clinic will introduce a new approach to caring for people suffering from dementia and their caregivers. The team will provide a full range of services that are working together to meet the shared goal of improvement of patient and family-centered outcomes. An additional aspect of this case that stood out to our group is the need for a trauma-informed care approach to best care for Bob and Jim. As mentioned in the previous slide, people living with HIV and those in the LGBTQ community are more likely to have experienced a past trauma in their life. And there's a growing number of aging people in these communities whose needs are not being met. Traumatic experiences can have a long-lasting impact on a person's mental and physical health throughout their life. Trauma-informed care acknowledges that trauma may have occurred and can manifest in people mentally, physically, and/or behaviorally. Particularly, these may manifest even more so after the onset of a dementia diagnosis. The goal of trauma-informed care is to maximize feeling of control and safety for all patients. This approach involves having every person working in the clinic having training regarding a trauma-informed approach to develop a trustworthy, nurturing environment that is safe for all patients. Next slide, please. The Advanced Practice Provider, or an APP, has the role of completing the initial assessment, reviewing imaging, and the diagnosis of the memory disorder. In this case, the APP has diagnosed Bob with Alzheimer's disease between mild and moderate decline. Bob has 7 out of the 10 Alzheimer's warning signs, a neurological exam that correlates with Alzheimer's, but with a rather rapid onset as opposed to a more common indolent decline. While his diagnostics support a diagnosis of dementia, such as the blood vessel changes seen on the CT scan and the hippocampal volume loss is seen on the MRI, the diagnosis is primarily one of clinical judgment and the exclusion of other causes. We diagnosed Bob with dementia of the Alzheimer's type, and the rapid onset may foreshadow a more rapid course than the normal decade or longer experience. Following the diagnosis, the APP has the responsibility of giving Bob and Jim the details of the prognosis of Alzheimer's disease and what to expect in the future. Unfortunately, the prognosis of Alzheimer's disease is poor, and the condition continues to worsen as the disease progresses, with an average life expectancy ranging from 8 to 10 years, but can range anywhere between 3 to 20. There is currently no effective disease-modifying or curative treatments for Alzheimer's. In addition, it's unclear if many of these treatments are clinically meaningful or improve the quality of life for patients. The medications come with side effects, add to the cost of medication burden, and may require frequent imaging. Thus, clinicians should provide Bob and Jim with the current evidence of pharmaceuticals available to allow them an individualized choice if they would like to pursue any of these options. The APP also has the role of initiating a care plan. The first step is creating a care plan is defining goals of care. To do this, an important step is to have a goals of care conference where Bob and Jim can determine their goals that are realistic and feasible to their situation. Next slide, please. Finding out individual hopes and goals of care are important because people in the same stages of an illness with similar levels of suffering will have different goals of care. According to the vignette, Bob seems to fall into the category of happy to be alive, but things like staying in his house, being safe, feeling better, and not becoming a burden to his family is way more important than living longer. Thus, the first goal Bob has is to continue to live at home for as long as he can. As he ages and the disease progresses, changes may occur and living at home may not be safe for him or Jim anymore. The care providers discuss maintaining physical safety as a key to fulfill this goal of living at home as long as possible, so this is added to Bob's goals. Another goal of Bob's is to reconcile with his faith and spirituality. And finally, he hopes to avoid living into late stages of disease and becoming a burden to his partner, Jim. Having Jim's own set of goals is also important. This is because understanding caregivers' needs leads to better care plans for everyone. Research has shown that people caring for a family member with Alzheimer's disease are at particularly high risk of negative mental and physical effects. Jim's goals include managing his own stress and maintaining his own health, minimize conflict related to dementia caregiving, and to keep Bob at home. It'll be important that Jim is coached to understand Bob's well-being is dependent on Jim's own well-being. Next slide, please. Now that we have Bob and Jim's goals of care, the APP can now start to develop a plan of care that addresses both of their goals. The first item on Bob and Jim's care plan that the APP will start is the advanced care planning process. An important piece of this process is filling out a POLST form. This form contains medical orders by a licensed provider such as an MD or an advanced practice nurse that reflect patients' wishes on what life-sustaining treatments they do or do not want to receive at the end of life. A POLST is different from other pieces of the advanced care planning process because it must be written and signed by a licensed provider. The POLST form can be modified at any time Bob or Jim's wishes change and as the disease progresses. The remainder of the care plan involved maintaining Bob's safety and addressing his current symptoms, balancing his medical complexity with his goals, and determining what other team members within the clinic will join Bob and Jim's team. Next slide, please. To best care for Bob and Jim holistically, the care team involved at this time includes, but not limited to, the advanced practice provider, a pharmacist, a physical therapist, occupational therapist, a dentist, a nutritionist, a social worker, and a chaplain. This current team is not the end-all be-all team for Jim. As needs change, so will the team. In addition, we believe having Bob and Jim as part of the care team is important, as the entire plan of care will surround what ultimately matters to them. Next slide.
All right, now moving on to the medical complexity of Bob's case. So Bob's current medical conditions include hypertension, hypercholesterolemia, type 2 diabetes. He has osteoarthritis in both knees, and he's also HIV positive, and now he has his most recent diagnosis of Alzheimer's dementia. So with his prognosis, our team wants to work with Bob and Jim to create an individualized medical plan that meets their goals while balancing Bob's comorbidities as well as keeping him safe. As a medical team, we want to reduce the risk of acute exacerbations as opposed to preventing events that may occur years in the future. As Bob's disease progresses, the intensity of treatment could be de-escalated. In addition, each medication should be consistent with Bob and Jim's goals of care. Thus, a risk-benefit discussion for each medication should be done by describing the indications, efficacy, safety, and cost of each medication. For hypertension, we want to focus on preventing any hypotensive or syncopal episodes, as they put him at a much greater fall risk. While his blood pressure is elevated into stage 2 hypertension at 150/94, without any personal history of ASCVD and no familial history of stroke or MIs, we recommend that the risk of additional antihypertensive therapy outweighs the benefits, and so just to continue the telmisartan 80 milligrams once daily. On the topic of cardiovascular health, Bob is currently on pravastatin 40 milligrams daily. Pravastatin is a moderate intensity statin, also a hydrophilic statin similar to rosuvastatin, so it has a low risk of any sort of statin-induced myopathy, which can become more prevalent with changes to Bob's weight and metabolism. Diabetes does put Bob at a higher risk of ASCVD, and so we could consider changing to a high-intensity statin, although Bob's prognosis limits him to fully realize the benefits of a high-intensity statin, and so the risks of adding on additional dosage may outweigh the benefits and not align with their goals of care. Bob's control over his diabetes has also slipped with the changes to his mental status, along with his ability to manage his medications, and in general, the risks of enforcing a stricter A1C goal outweigh the benefits for Bob. We want to focus on reducing episodes of hypoglycemia for Bob, as this can be a big risk to his health and cause further distress for both him and Jim. While Bob is on a fixed dose insulin, he has evidence of forgetting to take it, as well as possibly confusing his insulin with their pet dogs, and insulin in general poses a large hypoglycemia concern. Bob also has some evidence of diabetic neuropathy in his feet and possibly some signs of declining or changing renal function, although no apparent changes to vision at this time. We still want to continue with annual retinopathy and neuropathy exams. He also has occasional diarrhea, so we want to make sure he's taking his metformin with meals to reduce the risk of this medication causing diarrhea. And would currently recommend continuing the metformin at this time to have some management or level of control of his blood sugar. For Bob's osteoarthritis, we'll recommend a topical analgesic like diclofenac or Voltaren gel, but we'll also appreciate the recommendations from our physical therapy and occupational therapy colleagues here shortly. Bob's HIV viral load was undetectable at the time of last testing, and so we'll continue the necessary antiretroviral therapy as present. Our pharmacist is also concerned that Bob's taking Tylenol PM a couple times a week for sleep. Tylenol PM contains Benadryl, which can contribute to tiredness, confusion, and delirium, and have a further negative impact on his mental status. We would recommend melatonin, like 1 milligram at bedtime as needed if Bob still needs something to help him fall asleep. Bob's also been using ginkgo biloba supplement to help with his memory loss. And as Bob's symptoms are still progressing and the supplement has some drug interactions with Biktarvy and metformin, we'd recommend discontinuing it at this time.
So with Bob's new Alzheimer's disease diagnosis, we found that there was a drug therapy problem of indication needs additional drug therapy. This additional drug therapy may help symptomatic Alzheimer's between mild to moderate dementia that he is currently experiencing. Although there's no cure for Alzheimer's disease, there are available treatments to help improve the symptoms. These options can include acetylcholinesterases, NMDA antagonists, and disease-modifying therapeutics. We found that donepezil is a second-generation acetylcholinesterase and is the leading drug for Alzheimer's disease treatment. Donepezil can come in either an oral option or a transdermal option. Like Katie was saying, for Bob's Alzheimer's disease treatment, we really want to start out by having a conversation with Bob and Jim and any other caregiver that's going to be a part of Bob and Jim's life to gauge what they feel and think is best, kind of get a sense of what Bob wants to do, and really involve everybody in this decision-making process, since this treatment does not cure the disease, but instead has the potential to possibly improve the symptoms. With that being said, if they do decide to go with this treatment route, we would like to initiate donepezil 5 mg transdermal patch. The initial dosing regimen for this treatment would be a 5 mg per day transdermal patch applied to the skin once a week. When going back and forth between the transdermal and the oral, we chose this patch over the oral option since you only apply the patch once a week rather than taking the oral option once a day. We believe that this will be easier to remember, easier for Bob to manage, and improve overall adherence. After about 4 to 6 weeks, we can increase to the maximum 10 mg per day transdermal patch applied to the skin once a week again if the previous dose was well tolerated with no adverse effects or safety concerns. We'll follow up with Bob 2 weeks after initiation of donepezil to assess any potential side effects and talk about anything else that he or Jim would like to talk about regarding this treatment. And then we'll follow up again after 4 weeks to assess adherence, tolerance, and talk about potential titration.
In terms of physical therapy, we have 5 different management that can help Bob and Jim. So the first one is pain management. So basically, we will conduct a thorough assessment of the knee pain and then develop a personalized pain management plan. And then the second one is diabetes management. So we will educate Bob and Jim on the importance of managing diabetes to prevent complications that could affect mobility. And then the third one is peripheral neuropathy management. So basically, we will develop a sensory awareness program to help Bob manage numbness, pins, and then needles kind of sensation in the feet by providing recommendation for footwear or foot care to reduce the risk of complication. And then the fourth one is exercise adherence. So basically create exercise program that can be easily integrated into daily routine to enhance adherence. And then the fifth one is caregiver education. We will involve Jim in the therapy process to educate him on how to assist and encourage Bob with exercises and mobility goals. And then in terms of occupational therapies, we have 4 plans for Bob and Jim. So the first one is customized activity plan. Basically, we will develop personalized activity plans that are important to the individual's daily life, like basically Bob's daily life and interests. And then the second one is environmental modification. We will have people like actually go to Bob's house to rearrange like the furniture and then install some grab bars to enhance safety and independence. And then the third one is cognitive training. So we will provide cognitive exercises and strategies to improve memory, problem solving, and decision-making skill. And the last one will be sensory stimulation. Basically, it helps Bobs to engage with the environment, promote well-being, and reduce anxiety.
The social worker will play a large role in caring for Bob and Jim. They will first start by counseling Bob and Jim with advanced care planning as soon as possible, while Bob is still able to make decisions for himself. At minimum, the social worker will make sure to aid in the filing of a durable power of attorney of both finances and healthcare, in addition to a living will. These documents are important because they make sure that Bob's wishes are put into action by those who he would like to make the decisions for him when he's no longer able to. In this specific case with Jim and Bob, advanced care planning is very important to complete as they're not legally married. If these documents are not legally in place, the responsibilities of decision-making for Bob wouldn't go to his life partner Jim, but a relative such as a sibling. The social worker will also provide psychotherapy to Bob at first. Some key areas they'll focus on is Bob's past experiences caring for his mother with dementia and the feelings surrounding his current diagnosis, his relationship with his estranged brother, and the trauma of living through the AIDS epidemic. The social worker will also provide education and counseling to Jim regarding memory loss and caregiver issues to support Jim reach his goals so he is fully prepared for the progression of Bob's disease. If needs arise, psychotherapy can also be made available for Jim as well. In addition, the social worker will help refer Bob and Jim to concrete services that they may currently need, such as home health care or adult day programs. And they'll also help refer Bob and Jim to services in the future when needs arise. Finally, they'll aid in connecting Bob and Jim to reliable resources. One resource in Minnesota is the Violet Directory, which allows people to explore LGBTQ+ aging-friendly services throughout the state. And this will hopefully ease some of Bob's and Jim's concerns of the future of him having to recloset himself upon entering a long-term care facility. Additionally, they will connect Bob and Jim with support groups and give them information regarding forums, especially for members of this community. A final resource the social worker can aid in is supporting them to help them find veterinary aid for their furry friends that they're concerned of.
So from a nutritionist perspective, we had two important pieces to Bob's plan of care. So we saw both the active cooking and the nutritional value of food. Bob previously really loved to cook, and cooking is an important hobby to him. And so we could really imagine from the case vignette, we could really imagine Bob preparing meals for gatherings of large groups of friends, as well as enjoying to cook for Jim. But with Bob's changing mental status, complex activities like planning and cooking meals are becoming a lot more difficult and could become frustrating for him, which has led the two to order more fast food out as well. So as an effect of dementia, Bob's experiencing a diminished appetite as well, low fluid intake, and possibly trouble swallowing. So similar to our medical management plan for Bob, our nutrition management plan is focused on keeping Bob comfortable and also safe. So we'll work to optimize his nutrition to make sure we could work to optimize his nutrition to make sure his A1C, blood pressure, and cholesterol all remain in check. But we're much more focused on keeping Bob safely eating, drinking, and finding enjoyment in food. So our nutritionist is going to create a semi-structured meal plan with both Bob and Jim. And these are going to be like simple home-cooked meals that they're familiar with. And they'll be inspired by conversations with the couple about what they love to eat. The nutritionist will help Jim draft recipes and a grocery list to help alleviate some of this burden from Jim on this role that he's not used to filling previously. This way, Bob and Jim can cook a few meals each week, but this will help to eliminate a lot of the burden of a complex task like cooking while reducing the amount of fast food they are consuming for the benefit of both of their health. To reduce the risk of acute dehydration and exacerbations of comorbidities, we'll also have a discussion with both Bob and Jim to support Bob with adequate fluid intake. So we'll talk about strategies such as keeping a water bottle readily on hand, experimenting with some flavored water, thicker drinks as well. And due to more frequent coughing while eating and potentially a risk of aspiration, we'll also refer Bob to a speech language pathologist within our clinic for a swallow eval as well.
There's currently a lack of spiritual care and dementia practice guidelines. When spiritual needs and concerns go unaddressed, spiritual distress may occur, contributing to poor patient outcomes such as depression, anxiety, diminished quality of life, greater physical pain, and decreased emotional well-being. A recent literature review supports the importance of spirituality to people living with dementia in finding hope, meaning, coping with their condition, and connection to the past, present, and the future. Chaplains are professionally trained clergy members who can support patients in spiritual guidance using insights and principles of psychology, religion, spirituality, and theology. Since one of Bob's goals is to reconcile with this faith and spirituality practice, we found it pertinent to add a chaplain onto Bob and Jim's care team as soon as possible.
Some methods were given to Jim as Bob's caretaker that could help improve Bob's oral health, and they are as follows. Jim can create a routine where Bob brushes, flosses, and rinses at the same time every day after the same activity, such as 30 minutes after eating breakfast or after putting on pajamas before bed. Jim can purchase Bob an electric toothbrush, since this will allow for a more effective brushing, making it possible for Bob to maintain a healthier oral environment. Jim can help make brushing an enjoyable activity for Bob by playing his favorite music in the background. Jim can limit Bob's intake of sugary foods and snacks to help reduce the occurrence of dental caries, since preventing caries is vital in a patient who has difficulty maintaining their oral health. And Jim can take Bob to his regular cleaning every 6 months, which will allow Bob to be monitored for any changing conditions or any potential developing issues. Next slide, please. Bob has two systemic diseases, HIV and diabetes mellitus type 2, that are of concern when it comes to treating his oral health. If unaddressed, these two diseases can have greatly negative impacts on Bob's oral health. So it's critically important to keep these two systemic diseases under control in order to help keep his oral environment healthy and non-contributory to future oral issues. Considering Bob's rapid decline, it's best to monitor and prevent any oral issues from occurring. Given his condition, we are going to provide him with palliative care that will allow for maximum comfort rather than performing extensive treatments on him that could impact his quality of life. Next slide. Our care manager was our team's nurse practitioner, Katherine Burkholder. Our team worked together with the patient and family at the center of the treatment plan, and we respectfully communicated and listened to each other when discussing the treatment plan. Each team member worked with other team members to collaborate between specialties in order to put Bob and Jim at the center of the treatment plan. For example, the dentist relied on the nurse practitioner to help get control of the patient's systemic diseases. The pharmacist worked with the nurse practitioner to get the patient on the correct medications and dosages. And the nurse practitioner worked with the physical therapist to determine what treatment plan was most effective.
When it comes to interprofessional quality improvement, specifically regarding teamwork, we found that healthcare workers that communicate effectively and work collaboratively provide the best patient-centered care. If a team is really functioning the way that they should be, we can help to reduce the potential for error, reduce complications, enhance patient safety, and overall improve outcomes and quality of life for our patients. We found this out during this presentation as we'd meet up, talk about each part of Bob's care plan, build off of each other, and then work together to come up with the best care plan for Bob. We were all able to contribute, which helped lead us to what we thought was the best decision. We also found that each profession impacts patient outcomes and quality of life. For example, nurse practitioners are trained to assess medical tests, make diagnoses, and initiate and manage treatment plans. Our nurse practitioner student, Katie, did this for us. She completed the initial assessment, and the rest of us were able to take that and do what we needed to do for our role in the healthcare team. Pharmacists are trained to make sure medications are indicated, safe, effective, and convenient, or IESC, for their patients. Patrick and I went through each condition and medication, applying IESC, found any current or new drug therapy problems, and then made any changes that needed to be made. Physical therapists are trained to provide preventative care, rehabilitation, and treatment for conditions or injuries. Jan went through Bob's conditions, his living situations, and overall daily living habits to help maximize his quality of life. And last but not least, dentists are trained to diagnose and treat problems within the mouth. Oral health plays a large role in overall health, and if uncontrolled, bacteria in the mouth can enter the bloodstream, ultimately affecting other parts of the body. McKenzie was able to come up with methods to help improve Bob's oral health.
For interprofessional work and communication strategy, we always use clear communication to make sure that everyone is in the same page. And then we also encouraging questions as well as active listening. And then we also clearly outline the roles and make sure that everyone knows what is expected from them. And then we also have regular meetings to discuss our progress, share information, and then address any concern that we have. And then we respect and trust each other. We acknowledge and appreciate the expertise and perspective of all professionals involved. And then our team members also were able to provide inputs on the collaborative process and give some suggestions for improvement. And then we also maintain clear documentation by recording like other discussion or decision or action item to avoid. And then we also like kind of being flexible in approach as circumstances and requirement can be changed over time.
All right, so last part here, reflecting on our experience working on an interprofessional team and what we learned through this process, and some of the challenges that we had, and then sort of how we overcame them. So one of the major challenges I think we had was scheduling. It was really difficult for us to find times that all of us could meet, coming from different professions, different academic backgrounds, even different time zones, really different class schedules. We worked to find times that then the majority of the group could meet, and then filled in others as well as needed afterwards, either through email or we worked off Google Docs so we could see edit history and assign different parts of the project to each other, which worked really well. to help overcome that scheduling barrier. We learned a lot. Definitely the thing that we learned the most about was interprofessional value. Each of our disciplines, academic disciplines, professional disciplines, brings a huge wealth of knowledge. And we approach a patient's care very differently, but we all have a really similar end goal of helping the patient achieve their goals, as well as the goals of the patient's caregivers as well. Leadership is super essential as well to a highly functioning team. So we had Katie as sort of our star leader. So on an interprofessional healthcare team, a lot of times this leader is an MD or like an APRN, since they have like this most high level view of the patient's care. But it doesn't always have to be somebody in that position. And it's really essential that all members of the team are willing to step up and really own their part at times as well as needed. So that is everything we have. That concludes our presentation. We just have some slides of references here. And now I believe we'll take any questions.
Great, congratulations. You can stop sharing your screen when you're ready. And judges will be able to bring forward, maybe first judges could start with introductions and then bring forward some questions.
I'll start, I think, Teresa, if that's okay. So I'm Joe Gogler from the School of Public Health here at the University of Minnesota. And I'd like to ask the team this, and forgive me if you did address this in your presentation. I don't know if I heard it. So Bob says, what I overheard and you mentioning Aricept or Donepezil as a potential pharmaceutical treatment for the dementia. What if Bob said, you know, I heard those don't work very well. I heard there's a new FDA approved treatment called lecanemab. Tell me more about that. What would you tell him?
I'll maybe let one of my pharmacy colleagues respond to that, if any of you know anything about that drug.
Yeah, I think first off, we would, I think, praise Bob being such a great advocate for his own health and especially taking a deeper dive, look into his medications. I think it's important with a lot of Alzheimer's and dementia related medications that the efficacy, there's not a lot of great research on the efficacy of any of the medications. And I believe lecanemab is also much more expensive than Donepezil. So we might also look at some options of what insurance would cover there too.
Great, thank you.
I'll go next. I'm Marla Bergwager, St. Louis University School of Social Work, and I direct the Geriatric Education Center. Great presentation. What, if any, ethical issues arose during your discussions and preparation of the care plan?
Yeah, so I think the one thing that really helped was our coach to kind of guide our thinking process in regards to developing the care plan and specifically looking at what the vignette said about what Bob and Jim wanted. I felt like the vignette really clearly showed their goals of care. So we really didn't have too much of an ethical dilemma in regards to that. I mean, I hope so, if somebody had a concern in regards to that they would have brought that up, as I felt like I kept that open. But I don't know if anybody else has a different thought.
I think the main ethical dilemma we kind of came to in terms of Bob's care was making sure that his wishes are put forward, I think, throughout the duration of his medical journey as well, which I think was the importance of a pulse form to make sure that his wishes are honored late in the later stages of his disease as well.
Thank you both. I just also want to make a quick comment. I really appreciate the more extensive descriptions of what the disciplines would do that weren't on your team. It would have been easy to just, say, oh, and we would bring in these disciplines, but you really did clearly do some research and figure out what they could contribute. And I just want to comment on that. So thank you.
Did you have a question, Terry?
Sure, I'll go. Terry McCarthy. I'm a geriatrician in the Department of Family Medicine and Community Health, as well as internal medicine. Nice job, you guys. Very impressive. Glad to see that IPE is alive and well at the University of Minnesota, which relates to my question is as you reflect on this experience that you just had together, how do you think it's going to impact your perspective on your future practices? Has it changed how you view how you want to practice and who you want to take care of?
I guess I'll go first. One thing that really changed my perspective, because to be honest, I get really scared about the future as coming into the healthcare field and what's kind of going on and how we're having a huge, massive change that nobody has ever seen before. And this really solidified that I can step into this role as a leader to help change some of the things that is kind of maybe going wrong in our system, and how important it truly is to have a team and having a team that surrounds a patient's actual wishes, because that's really what truly matters. And I think that's what this whole experience did for me.
Hi, I'm Elena Osterberg. I'm with SLU in clinical health sciences. And one of my questions were, and maybe I missed this too, but I was thinking of Jim and sort of the caregiver burden issues that he has expressed, and was wondering how you feel that should be addressed.
Yeah, absolutely. I thought I had maybe mentioned something, which Jan, do you want to maybe jump on?
Yeah, I can talk a little bit about that. So yeah, like Jim has like some burden, like don't know how to take care of Bob. So that's why we want to involve Jim into like the treatment session, like actually teach him like how to get Bob involved on this, and then like show him like how can we actually encourage, like the way we encourage Bob to do something.
Okay, I guess what I'm thinking is finding Jim some help. You know, Jim has sons, and reaching out maybe to his family.
Yeah, absolutely. And if you would go back to, or I guess you can't go back and see, but in the social work section, I did address some of the areas, because I actually just recently learned like how important it is when a caregiver has their own plan of care, because it makes a better overall care of the patient when their caregivers being taken care of, because caregivers are really taking the burden of a lot of patient care right now. And we can't forget about them. We really can't.
Thank you. You guys did a really impressive job. Thank you.
Allison, do you have a question?
Sure, thank you. Hi, I'm Allison Gibson. I'm an associate professor in social work at SLU. And I wondered if you could elaborate a little bit on, I really appreciated you talked about wanting to approach it from kind of a trauma-informed care lens, which I think is so important with this patient. How would you kind of work to maybe build trust with Jim and Bob, as well as maybe any other family members that are going to be involved in this case?
So I think the first thing that we can do, like when we first meet Bob and Jim, we can tell them like, hey, we're gonna do this all together. We have like plan to like actually show them like first we're gonna do this, second we're gonna do that, and then like actually show them that we have like a whole plan, and then if we follow the plan, if we see the progress, we can always add things up to like build the trust in between us, because like we don't really know each other, but in order to build trust, we have to like show them what we have and then how can we help them.
I think another way that we could build their trust as a team is to reassure them that we want to keep them and their wishes at the center of our treatment plan and plan of care. So I think that that would really be a very important foundation to build that trust with them.
I think I'm the last judge with a question. So I'm Chris Talley. I'm a associate professor in nursing at this University of Minnesota, and I'm also a gerontological nurse practitioner. First, I want to say I was really impressed with your vision for creating this trauma-informed clinic of the future for these high-risk people. So I want to compliment you on that vision of that. And I guess the question I would like to ask you, though, is what did you learn about another discipline that you were surprised by or didn't know that they would be able to do? And if each team member wants to comment on that, I'd appreciate it.
I think what I was most surprised by is how much the nurse practitioner plays a role in the center of like who you go to say, hey, what about this? What about this? You know, I went to her with a lot of questions and I really think she stepped up. So I was surprised at how much she actually had a hand in it. So great job, Katie.
I can speak on that next. I'm a pharmacy student, and so I presented a little bit on both the pharmacy and filled in the role of nutrition as well. But I was most impressed with the role, I think, of physical therapy and occupational therapy. So that's not something that I'd previously been exposed to, and how much of a role that they can play in a patient's care, especially for Bob's care specifically with like diabetes and managing peripheral neuropathy and all sorts of environmental modifications as well to their home and to help make it like a safe environment for him. That's not something that I've ever been exposed to previously in school or practice. So
I was really impressed with McKenzie in dentistry. After this presentation, I did some research into dentistry after looking at her slides, and I realized how much oral health plays a role in the body as a whole. So I was really impressed by how much that what seems like a little part of your body can bring so much into a case like this.
I'm really impressed on pharmacists because I didn't know that like when they try to prescribe medication, they actually have to follow like, I don't remember like the thing that you mentioned just now, but it's just impressed like we have like different types of medication that treat the same diseases. Like how can you decide like what kind of medication that we can use? I don't really have that knowledge, so it's really impressed.
I was impressed with McKenzie. I've never worked with a dentist student before, so that was really fun. And the same with Alyssa. I was pretty inspired by looking at the view of the mouth as like, you know, a holistic part of a person, and inspired me to maybe pursue my DNP project in oral health or oral care in the hospital. So I'm very impressed with dentists and all the work that they do.
Right. Well, thank you, University of Minnesota team. And we'll give you a round of applause for all your hard work and the great teamwork that I think is evident with you. So the winner will be announced tomorrow. So celebrate tonight, though, for getting through this far.